Wonderful. We have some great experts today. I'm really excited for this.
Oh, hello. Okay, we have, thank you from Indonesia. From Zimbabwe. Welcome.
Hey, representation over here. Fantastic.
All right. UNICEF Sudan. Hello, welcome.
UN representation today.
Just a few minutes. Cambodia, yes.
Yeah. UNICEF Cambodia. We really got the UN folks in the room.
Yeah.
All right. All right, Joanne, whenever you're ready, we can get ourselves started.
Okay, we're still 1 minute off here in Atlanta.
Oh, excuse me. We're fast in DC.
You're faster in DC by 60 seconds. Can you imagine that?
Classic.
I know. We do want to get started close to on time, as close as possible. And it is now 9 o'clock Eastern in Atlanta, because we do have a really packed session. So good morning, good afternoon, good evening to everyone. I would love to welcome you to the Washington Healthcare Facilities Community of Practice Initiative. We're really glad to have you join us today for a special kind of session, just a little bit different than what we've done in previous webinars, where we're asking a WASH and healthcare facilities expert. So we surveyed you, the community of practice, a few weeks ago and asked you to let us know what are the most pressing questions that you would like to have answered about WASH and healthcare facilities. And you all came through like stars. We received some very thoughtful and provoking questions that helped guide us in putting together this session and gathering the panel of experts that we will have. They'll be responding both to pre-submitted questions and then live questions that you can still send through the Q&A function on this Zoom webinar. As always, I want to acknowledge that none of this would be possible without our wonderful community of practice learning team who planned, organized all of our speakers today and everything that we're going to do. So first, I'll introduce myself. My name is Joanne McGriff. I'm assistant professor within the Department of Global Health here at the Rollins School of Public Health at Emory University, as well as core faculty within the Center for Global Safe Water, Sanitation, and Hygiene. I have with me part of the community of practice team, Lindsay Denny from UNICEF New York, who's also a longtime affiliate with the Rollins School of Public Health, Haley Elling from World Vision, and again, great job on putting this session together. And then we have several members of our community of practice steering committee members somewhere in the virtual audience. These are the great partners who provide guidance and input into conceptualizing and implementing these sessions. So really grateful to our steering committee members who could join us. And we're also very pleased to welcome our esteemed guests who will serve as our expert panel today. The panel is going to include Saeed Yasir Ahmad from International Medical Corps, who's going to be responding to inquiries regarding WASH and healthcare facilities in emergencies and fragile contexts. I'll tell you a little bit more about Yasir's work. We have Ute Pipa, who is from WHO, who will be addressing the many questions we received around healthcare waste management. We have Claire Kilpatrick, who's also from WHO, who helped us address several questions related to infection prevention and control, or IPC, in WASH and healthcare facilities. And then we have Rahima Panwar from WaterAid Pakistan, who helped cover the COP's interest on gender equality, disability, and social inclusion. So we are so very grateful to have these experts graciously agree to come together to address these topics to the best of their ability. Once again, this is a jam-packed session, so we hope you're able to stay and then share the information you receive from the session. Of course, you can always refer to our Community of Practice YouTube channel or our webpage to view the video after we post it. So let's go ahead and get started. Next slide. Want to let you know other members of our community of practice team include the interpreters who will be assisting us today with Spanish and French speaking participants. In fact, if you haven't already, please go ahead and choose your language of choice in the bottom toolbar. We're asking those who are also English speaking to also choose English as their primary language in the toolbar just to facilitate smooth transition. Next slide. Before we launch into our session, it's going to take a few moments to welcome new participants to the COP and tell you a little bit about what we do and who we are. We are an action-oriented learning platform that brings together the WASH and health communities to focus on policy, evidence, and practice in WASH and healthcare facilities. Our goal is to connect the expertise and experience of our partners and colleagues to the members of the WASH and health community who've expressed interest in taking action in WASH and healthcare facilities. We've created this platform as well as our newsletter, our webpage, our resource hub on our webpage. And really all of that is fulfilling our goal so that after each session, you're able to walk away with some tangible information and then follow up on it, review it again at your discretion. That will allow you to be able to take the most immediate steps to advance improvement of WASH and healthcare facilities. Next slide. Also want to remind everyone of our guiding principles that really are undergirding this COP so that you really understand where we're coming from as we put together these webinars and what you see in our newsletter. So again, WASH to us is a fundamental prerequisite for quality care within a healthcare facility, and there can be no effective infection prevention and control, or IPC, without adequate WASH. We also believe that WASH and healthcare facility issues are solvable, and that in order to do that, it'll require multiple systems, sectors, stakeholders. It's multidisciplinary that have to work together to see sustainable improvements. And then lastly, that this community of practice is really open to all who seek to learn and share as it relates to WASH and healthcare facilities. So whether you're a seasoned expert on WASH and healthcare facilities or someone for whom this topic is brand new, we welcome you, we respect your perspective, and certainly appreciate your participation. Next slide. So each time we come together, we want to make sure that you have the latest information and resources on WASH and healthcare facilities. Many of you may already be aware of this the June 2023 new global report entitled WASH, Waste, and Electricity Services in Healthcare Facilities. This is the Global Progress Report put out by the WHO and UNICEF. The report provides a review of progress made across 73 countries since the World Health Assembly's 2019 resolution, particularly in the technical elements of the 8 practical steps. It also provides details on successful strategies and challenges faced by countries implementing WASH and healthcare facility programming. A few bullets on the key recommendations from the report focus on system integration of WASH at all levels, and regular monitoring and strengthening accountability, as well as empowering the workforce to deliver these services and practice good hygiene. Okay, so if you haven't already, please take a look at the new global report that just came out last month, or at least 2 months ago. Next slide. Another important feature of the global report is the analysis of the country progress tracker. Again, you may recall that this is a continuously updated tracker that focuses on the 8 practical steps and includes progress from about 70 countries, I think at this point, that have submitted their information. Again, very useful resource that can be found on the washinhcf.org website. Next slide. Another useful resource on the washinhcf.org website include the country progress posters. Now, these posters were presented at a June 2023 WHO and UNICEF Global Summit on WASH, where 33 countries discussed where they were in their programming. And you'll find that these posters provide a very nice summary of country activities, challenges, next steps, all kinds of considerations for what they are doing in WASH and healthcare facilities. So again, take a look at some of these posters. Next slide. What we also like to do is highlight stories in what we call our success corner, where the community of practice has an opportunity to showcase successes, wins, progress in WASH and healthcare facilities, great or small, however you define it. For today, we have a story from NCV Nepal that focuses on WASH Fit implementation. Many of you have already heard of WASH Fit, and this was done in 10 healthcare facilities in Pradesh province in Nepal, where they saw transformational change in community engagement, leadership of local government, and ownership by the healthcare facility staff in their collaboration to address and resolve Washington healthcare facility challenges. This is a big win for this group as these facilities are seeing positive health outcomes related to the improvement of the quality of the healthcare services through the improvement of WASH. So we really do celebrate with them and thank them for submitting this story. So now, without further delay, I want to turn this session over to our experts and begin with some additional introductions so that we will not only know who we have with us, but a little bit about their background. After I introduce the panelists, I'm going to start the session with one question that they will all comment on, and then move to either some pre-submitted questions or to questions that you can go ahead and put in the Q&A portion of the Zoom webinar. So if you would, just take a brief moment, take a look at your toolbar, wherever it is, across the bottom, across the top, and find that Q&A button, because that's the only feature we're going to use today to collect questions. While we have the chat available, and we do like to chat, and we encourage you to use the chat to comment and make other ideas, we can't use the chat today for questions. They might get a little bit lost. So we do need you to go ahead and put the questions in the Q&A only so that we can keep track and make sure that we're hearing from you. So with us today, I mentioned before, we have Dr. Ute Pieper, who is an expert on healthcare waste management. Dr. Pieper got her PhD in environmental technology and engineering and has gained more than 20 years professional experience in the field of healthcare waste management by implementing and supporting projects in more than 40 countries within Africa, Asia, and Europe. She is the focal point for healthcare waste management of the WHO WASH unit at HQ in Geneva. So welcome, Dr. Pieper. Saeed Yasir Ahmad is an expert on emergencies and fragile contexts. Mr. Ahmad is an accomplished water and waste professional, in particular in the area of WASH and in the context of complex and challenging public health emergencies, including management of COVID outbreaks, containment efforts during the Ebola crisis, handling WASH issues and man-made conflicts, and providing critical support in the aftermath of natural disasters. So this includes WASH projects in healthcare facilities and taking into account the unique challenges posed by emergency contexts. So Mr. Ahmad, we're so very happy to have you, because this is an important piece that we've not been able to cover before now. We have with us Ms. Rahima Penwar, who's an expert on gender equality, disability, and social inclusion. Ms. Penwar has more than 20 years of experience in the field of gender mainstreaming, legislative advocacy, strategic planning, promotion of religious and social harmony, as well as social justice, cross-sectoral networking with legislators, government, civil society, and political parties. So very experienced in these matters. She has her MS in social sciences with a specialization in gender and human rights from SZABIST in Karachi. She is a member of multiple bodies supporting women's and children's well-being, including the Sindh Commission on the Status of Women. She has served as WaterAid Pakistan's gender advisor since 2020. So welcome, Ms. Penwar. And then last but not least, we have Claire Kilpatrick, who is an expert on infection prevention and control, IPC. Ms. Kilpatrick is a graduate of the University of Glasgow, where she has a PG DIP in infection control and an MSc in medical sciences. She has been a consultant with WHO since 2008 and works as an IPC expert with a focus on development of implementation, improvement, and training tools, including addressing the intersection between IPC and WASH, which I know so many of you are interested in because we saw your questions. She has a wealth of experience in campaigning and is widely published in her specialist topics. She's a board director for the World Surgical Infection Society and as an expert advisor to a charity called the AMR Narrative, as well as being a member of the Royal College of Physicians and Surgeons. So I have spoken a mouthful because we have some really tremendous experts here who are quite knowledgeable and very experienced. And I'm so very excited to get us started. So while you've been listening to me and hearing all of the different focal areas and topics that these people really have spent a lot of time working and focusing on, please go ahead and start thinking about questions that you would like to pose. This is your time. This is the Ask the Expert session. And so go ahead and start using that Q&A function. But I'm going to go ahead and get started with the first question that I'm going to pose to each of the speakers. And I think we'll start with Dr. Pieper. And I'm going to use first names because I think it's a bit easier and more sort of like our style here, Ute. If you would start, the first question to all of you is, what resource has most helped your work, and in your case, Ute, in healthcare waste management in the last 2 years?
Well, actually, it's not only in the last 2 years. So here we are talking about the Blue Bible of healthcare waste management. It's the WHO book on the safe management of waste from healthcare activities, which has been revised in 2014. And this is kind of the most comprehensive guidance on healthcare waste management, which is tackling all areas of healthcare waste management, from classification and segregation, from risks, legislation, wastewater as well, treatment, disposal, emergency situations, occupational safety, really everything, which is also therefore quite a big document with more than 300 pages. But there you can find so many information about healthcare waste management, and I'm always getting back to this Bible, which is really the fundamental resource of healthcare waste management. However, the newer one has been published in 2019. That's an overview of treatment technologies for infectious and sharp waste from health facilities. And this is something which is quite useful, especially because there are always so many questions about treatment of healthcare waste. And this is really helpful because it is really comparing different treatment technologies, advantages, disadvantages, and needs, and so on. And this is really helpful as well. So I would like to mention these two core documents at this situation. Thanks.
Thank you so much. And I believe Haley has dropped the link to at least one, if not now the second one, in the chat, so you can know what Ute has referred to. So thank you so much for that response. I'll turn now to Yasir. If you could please go ahead and respond. What resource have you found to be the most helpful in your work?
Thank you. Regarding the emergency context, the promotion of specialized guidelines, which is looking into water sanitation and existing water supply, adequate sanitation, and promotion of hygiene messages. These guidelines helped us to maintain a safe and healthy environment for patients and staff. Having a rapid response kit preposition is critical. These kits are vital and include water supplies such as water purification tablets, hygiene items, sanitation items. They are specially designed to promote and provide swift assistance during the emergencies and guarantee adequate care to these such circumstances. The classic examples from IMC would be coming from the WHO EMT certification, where IMC is certified as the Type 1 mobile and a fixed facility, and our mission ready packages. On top, the WASH training modules for emergency responders provided training materials and modules to healthcare workers and other responders. Thank you.
Great, thank you so much. Again, as you're hearing some of what is being shared, please go ahead and feel free to put some questions in the Q&A. Again, thank you, Yasir, for your response. I'll turn now to Rahima. If you would respond also as it relates to the most helpful resource that you found as it relates to WASH and healthcare facilities in your work.
Thank you, Tony. When we talk about the WASH and healthcare facilities, Water Aid Pakistan started working in healthcare facilities from last 3 years. We are actually implementing 2 projects, one in Sindh and one in Punjab. The project we are implementing in Sindh province that is actually focusing on the sexual reproductive health services. And through that, we are actually trying to improve the WASH facilities in schools and healthcare facilities as well. So when we started working in healthcare facilities, we actually find the most helpful tool that was a accessibility and safety audit. We actually used to determine the special needs of women, young girls, and people with disabilities, pregnant women, elderly people, and also people with special abilities to actually to assess their special needs with regard to infrastructure and also their accessibility issues to quality health services. And I'm saying that based on that tool, we actually succeed to design our project. And now when we are in the end of the project, we are seeing that most of the, based on that tool we used, we actually succeed to engage women organizations, women, people with disabilities, transgenders, vulnerable community groups in the management of healthcare facilities. And that tool also helped us to actually to identify the capacity gaps of that particular healthcare facility staff as well. And we address those. And now we are seeing that number of patients with the passage of time has been increased. Particularly women are coming, young women are coming with the complaints of UTI infections, and now they are able to receive actually educate knowledge so they can improve their health and hygiene. Thank you.
Thank you so much, Rahima. And is there any template or where you can share with us this assessment tool that you use?
Yes,
I find that fascinating that you were able to do this gap analysis, if you will, to understand what these different groups are experiencing. And also that you use the term GEDSI, which is the acronym for Gender Equality, Disability, and Social Inclusion.
Yes.
And I think that's just so, important for us to understand how to do these kind of assessments.
Yes,
So if
and we are also testing this in another new project we just initiated last month in Punjab that is actually focusing on the gender responsive, climate resilient health wash services in healthcare facilities.
Great, wonderful.
Thank you.
Again, if you're able to share those assessments in the chat,
Sure.
please go ahead. Otherwise, we could always send it out to the community afterwards. Thank you so much for your response. And now we turn to Claire. If you could, in your capacity regarding IPCs or infection prevention and control, what have you found to be the most helpful resource within the last few years?
Thank you so much. So I have two, like Uti. I take advantage of bringing to you two resources that you maybe won't be aware of. And I think importantly, I want to explain why they've been important to me, but may be important to others. So the first one is the Global IPC Strategy, which was only launched last year by WHO. And that really does outline the future for infection prevention and control. So in these last difficult years, although full disclosure, I don't work in emergencies. We won't be talking about IPC and emergencies specifically today. But in these last challenging years, to have a strategy and have all the work with all member states, all countries going on during difficult times has been motivating for me. But I think that we can come back and talk more about this, but for others to recognise the importance of such a strategy, having been launched last year at the World Health Assembly, really should motivate all of us to recognise that there are elements of IPC suitable for all of us, and that we have a place now to use this without maybe being as challenged or finding so many barriers. The other thing that came out during these last years, a very practical resource, and they are 3 aid memoirs, initially initiated by the European region of WHO in those countries, but they are around hand hygiene, respiratory hygiene, PPE, environmental cleaning, waste and linen management. And there are action checks that explain what needs to be done to improve the situations around all of those IPC topics. And the exciting thing that we found working on them was that we were able to draw out those intersections between IPC and WASH. So for example, always having an action around annual water service plans to make sure that's in place to facilitate IPC practices. That hasn't always been the case in IPC documents. So I think we've seen some progress. So a really practical example there, and similar, the IPC strategy crosses over all the elements of IPC and WASH, which is really exciting.
Well, that does sound very exciting. And if possible, I know Haley has dropped the link to the WHO Global Report. If possible, Claire, you could put in the link to that. Oh, there it is, the second one. Right there, so that everyone can take a look and see. I think this idea of having a checklist can be so very helpful to those who are doing these kinds of assessments. So thank you so much for that. I see there are questions coming into the Q&A. Thank you so much for putting them in. What I'm going to do is go ahead and turn, because we got several questions prior to this session on healthcare waste management. And so I wanted to put to Ute, if you would talk with us a bit about what healthcare waste treatment technology is available to low resource settings and where incineration is not an option. Can you help us with that question?
Yeah, thank you very much. You're starting with a very difficult question. So actually we have well, the problem is always I cannot really answer this in detail, because this always depends on the facility, on the situation, the infrastructure, available water, electricity, and so on. So in general, there are some possibilities when incineration is not an option to go for, especially for autoclaving, and there are some simple autoclaves which can be used so also for smaller facilities like tabletop autoclaves, which do not need three-phase electricity. They just have the single-phase, so normal electricity, which can be used. And well, normally autoclaves also should be used with softened water, so demineralized water. But also here, some of the autoclaves are a bit more flexible on that, and there might also just be used like just rainwater, which is much softer in most cases than the tap water. So there are possibilities which can be used, but this is always depending on the kind of facility and the infrastructure available in the setting. So this would be my next step if I cannot go for incineration, just to check if there are possibilities to use autoclaving in these settings.
Great, thank you so much. And I'm sorry that we hit you with such a hard one to begin. But I think that's a really great answer, because it always is so context specific, right, in terms of what is available. So we appreciate you providing that perspective. So I'm going to shift really over to Yasir regarding programming in fragile and emergency contexts. And here the question was, what really differentiates WASH and healthcare facility programming in fragile versus development contexts? And so if Yasir, if you could talk about that a bit.
Thank you. In fragile areas, healthcare facilities often experience significant disruptions caused by the ongoing conflict, political instability, or natural disaster. This results in damaged infrastructure, limited resources, and reduced access to essential services as WASH facility. What are our immediate priorities? The primary focus in such contexts is establishing or restoring basic WASH services in healthcare facilities to ensure infection prevention, control, and safe healthcare delivery. Addressing urgent WASH, IPC, RCCE needs becomes a priority. Our approach to WASH programming in fragile contexts needs to be flexible and responsive to readily changing solutions or situations. Emergency preparedness and response plans are critical to deal with the unexpected spikes in healthcare demand and WASH requirements. When we have security issues in conflict zones, they may affect the safety of water sources and sanitation facilities, making it challenges to maintain the hygiene standards at the healthcare facilities. What are we doing in the development context? First, let's highlight the challenges that are faced. Although development contexts may have more stable institution and infrastructure, disparities in access to WASH services can still persist, particularly in rural versus urban contexts or underserved areas. Regarding the WASH programs in development contexts, the focus is on long-term sustainability. This means planning by prioritizing infrastructure maintenance, capacity building, community engagement, and by doing, we can ensure everyone has access to safe services in healthcare facilities for years. In development context, WASH programming can be integrated into large public health initiatives to acknowledge the connection between the hygiene, sanitation, and overall health care outcomes. This helps to support public health initiatives and promote better health outcomes. Both in fragile and development context, the main objective is to provide healthcare facilities with improved access to safe and dependable WASH services. This is critical for preventing infections, decreasing healthcare-associated diseases, and achieving better patient results. In both contexts, effective coordination and collaboration amongst government, NGOs, international agencies is necessary to implement and maintain WASH programs to healthcare facilities successfully. Thank you.
Great, thank you so much, Yasir. And I think, the distinctions that you're making in terms of sustainability and integration are so very key for us to understand those differences with fragile versus development context. I thank you for that discussion. Again, I encourage you to continue putting questions in the Q&A as this conversation moves forward. I want to shift over to Rahima and a little bit about gender equality and thinking about services that relates to girls and women. One question that came in is, how do you include and design effective and sustainable menstrual hygiene management activities in WASH and healthcare facility interventions? So if you could talk with us about that.
Okay, thank you for asking this question. Actually, you know that WaterAid Pakistan's one main area, focusing area is menstrual hygiene management. We are not only engaging at national key stakeholders at provincial level, but at district level as well. And we are running a MHM national campaign, and we have engaged provincial task forces and technical working group on MHM. In Sindh province particularly, we are implementing a sexual reproductive health program with the support of Global Canada Affairs Fund. And that project is basically on the promotion of menstrual hygiene management. So when we talk about the menstrual hygiene management, we actually adopted numerous approaches under that particular project. And I advise that whenever any organization is intent to work on the promotion of menstrual hygiene management, they first actually engage with the political leadership of the relevant departments. Either it can be health department, it can be education department, it can be public health engineering department in terms of in the context of Pakistan, it can be local government department. Because in Pakistan, there are various departments, they have actually working with integrated approach, and they have these similar kind of mandates. So engaging with them, there is a need to actually conduct a gap analysis on available MHM policies and strategies. So based on that, they can actually design that what kind of initiatives or what kind of support they will be needing to provide the relevant departments, like we also did in Pakistan. And then influence on relevant ministries and departments to ensure that WASH, particularly when we talk about MHM, is incorporated into health programs and financing platforms as well. Because when we talk about the menstrual health, to ensure the availability of sanitary napkins, there is a need to actually develop inclusive sanitation services, particularly with regard to ensure the availability of menstrual hygiene management services. So this kind of initiatives need financial resources as well. And with regard to ensure their services, we need to engage with relevant finance departments as well. Then we need to create, that when we talk about the menstrual hygiene management, there are a lot of misconceptions within community and within healthcare staff as well. So there is a need to actually raise awareness among the healthcare staff, among the communities, to actually embed the MHM in healthcare staff training modules, and also in education, school teachers and students as well. Like we did in Pakistan, that we not only developed training modules for the teachers, master trainers, but also we also revised the curricula of midwives and lady health workers, which we actually commonly call them as a community health worker, so they can actually reach out the communities and raise awareness about to eliminate the misconceptions as well. And when we talk about the menstrual hygiene management, it is most important part to actually promote the inclusive sanitation services. When we talk about the inclusive sanitation services, it means that there should be there should be a space where women can actually change their clothes. They can actually use toilet. They, in case of any they can wash their clothes, and they can also look that if there is any kind of material is put on their shirt, so they can wash. And they can also we can also ensure their safety and privacy and dignity through the availability of these sanitation services. We have actually created models, and we demonstrated these models to health department and education department as well. And I'm feeling privileged to share that following the demonstrated models and the success of those models, now health department is actually agreed to incorporate these kind of MHM services and inclusive sanitation services within their programs. There is also another good thing that when we talk about the healthcare staff, either it's technical staff or non-technical staff, but unfortunately they have little information about the menstrual hygiene management. So after the engagement, after their trainings, now they become able to actually counsel the youngers. They are actually menstruating, and they are actually creating an environment and and creating awareness among their mothers as well, that what kind of environment, what kind of support they can provide being a mother in their house. Thank you.
Thank you so much, Rashima. I mean, wow, you've covered so many bases, and I really am very impressed with just the way that you have taken this community-centered, or our friends in architecture would say user-centered design approach. It's multi-level in terms of the way you are talking about the different levels have to be involved in order for menstrual hygiene management services
Yes.
to be truly sustainable and effective, and multi-departments. It sounds like
Yes.
involved.
I just want to add that beside this, we also engaged influencers at community level. Particularly, we call them community MHM champions. There are district MHM champions, there are provincial MHM champions, and their role is basically to provide enabling environment to other women. Either they are working in a school, either they are coming in hospital, either they are going into market.
Again, it's focusing on the community. Thank you so much for that response. I'm going to turn over to Claire, because we got a couple of questions here regarding IPC, and they're a bit related, but I'm going to ask the first one, where the question is, in your experience, what has been the driver of national or subnational health system investment in IPC improvements in low middle income countries? The second question is a bit related, about IPC governance mechanisms, specifically at the national level. So you can choose to respond to the first one, you can combine them, however works best for you.
Thanks, Joanne. Yeah, I mean, I think that's a really interesting question about the drivers at national level, because I do think they will vary across a range of countries. However, I think related to the second question is quite clear from a governance of accountability perspective that we are fortunate since 2016 for all countries to have access to the core components for infection prevention control. So these are evidence-based guidelines that were then translated into implementation manuals and assessment tools. And one of those assessment tools is for use at the national level. So that those national level indicators that are based on the evidence we've found from the literature, and indeed that's been updated right now to keep these tools current for all countries. So those indicators at national level since 2016, I mean, that's quite some 7-8 years ago now, it's quite scary, 7 years ago, then actually we have that written down. We have those accountability steps about, does your country have an IPC program? Does your country support HAI, healthcare associated infection surveillance? Does it support other audit and monitoring? Does it support training and education? So those elements of the core components are there. And we've also, and Hayley posted about the global report, and there's specific results there on the global survey for infection prevention and control using these indicators. So although that takes buy-in from countries, it takes governments and other leaders to be motivated and interested, we do have the tools that are helping us to take that journey. And I also think that there has been consistent messaging across a number of programs that has supported the IPC agenda, and that has included the WASH agenda. That includes a number of documents that actually talk about IPC and WASH together. So that's reaching a new audience with consistent messaging. We've got the quality of care agenda, we have patient safety agenda, we have antimicrobial resistance, and having IPC and WASH embedded in those areas, I think has also helped raise the profile. And those topics, for example, WASH and patient safety, have had what we call these resolutions at the World Health Assembly in previous years before the IPC one. So I do think the key word of what I'm trying to say here is probably that collaboration, and that one voice is making a difference and is engaging that national level more every year.
Great, thank you. And that's really great news for all of us to hear, especially the availability of those indicators and the action that's being taken now on those in these different countries. So thank you so much, Claire, for those comments. I will say, if you are interested in having your questions featured, please make sure to put them in the Q&A function. There is a button on your toolbar that says Q&A. We're not always able to follow the chat. So please, if you have a question, put it in the Q&A so that we can at least log it in and do our best to try to cover it while we're in session today. The question I'm going to turn to actually just came in, and I'm going to turn to Rahima, asking, how have you engaged women, particularly health workers, patients, community members, in WASH in healthcare facility design and programming?
Thank you for asking this important question. When we talk about the engagement of women, particularly either they are working in healthcare facility or at community level, we, before initiating any project, we are actually trying to conduct a gender analysis so we can see that what kind of barriers and challenges women and girls are facing, and in terms of what kind of division of labor is there in particular community, and if we intend to engage the women at community level or either at the management committees at healthcare facility level. So is there any enabling environment so we can engage them? So like I already shared you that we are implementing 2 projects in healthcare facilities, and we are trying our best to actually form management committees at healthcare committee, at healthcare facility level, in which we are actually giving representation to community women as well, so they can actually become the part of those management committees and ensure the quality services, and also work as an ambassador within communities as well. And when we talk about the healthcare facilities, like you know that when we talk about the gender inequality, we also find that there are various key sectors where there are only few women. Like in rural areas, we hardly find a lady doctor, we hardly find a community midwife, though there are lady health workers, community health workers working in the communities. So through our policy and advocacy work, we are actually trying to influence to political leadership and policymakers, decision maker, to appoint more women, particularly in the healthcare facilities level, particularly at primary healthcare level, because we know that if there is a woman and she needs a counseling, if there is no any other women in healthcare facility, then who will be there to actually counsel her or provide her basic information as well. So these kind of initiatives we are trying to actually take, and ensuring the women's participation in decision-making bodies. When we talk about the WASH, we also learned with the passage of time that if we change the dynamics of the WASH sector, we need to adopt the approach of gender transformational approach within WASH sector. And through that, we can actually promote women leadership at community level, like under various projects. we are forming the women-led oversight committees, and this is completely a new phenomena, that when we talk about the WASH, and WASH is considered a technical subject. So community women are giving opportunity to actually come sit together to discuss the challenges or problems the community women are facing. We are also trying to actually build a gap between the service providers and right holders through those platforms.
Thank you so much, Rahima. And in your, again, very comprehensive response, I feel like you've given us ideas on how to include and engage women in all of these different processes. So thank you so very much. Hopefully everybody will take time to just sort of think about everything that Rahima has shared about what they're doing and the approach that they're taking. Thank you so much. I'm going to move back over to Ute regarding healthcare waste management. The question is, I have observed that waste segregation is getting better and better, but when it comes to collection and disposal, especially of infectious waste and maybe general waste, those tend to come together in the burner at a healthcare facility, especially in areas where there's no general waste collection. So what should we do? What intervention would we need to introduce? So hopefully, Ute, you caught that question.
So first of all, I'm very happy to hear that segregation is getting better because this is something which I do not experience pretty much. So so when segregation is getting better, that's always, you know, thumbs up. So because this is the key activity in healthcare waste management. So without good segregation, there's everything will get difficult afterwards. However, that the waste is afterwards then mixed up again is of course a no-go. So this should not happen at all. So if you mix up the waste afterwards again, then all the waste has to be considered as infectious again. Yeah. So that doesn't make sense at all. So it's really important to keep these waste streams separated, and they should also not be incinerated or treated together. So when we talk about incineration, actually, we always have to distinguish between a hazardous waste incinerator and an incinerator for general waste. So these are two different types of incinerators because they are using different temperatures as well. So for the hazardous waste, you need higher temperature. So like the two-chamber incinerators, which are recommended in accordance to the Stockholm Convention. We have the first chamber with 850 and the second chamber with 1100 degrees. And for the general waste, these temperatures are lower. That means also that in case you would mix up the waste and incinerate this waste properly with high temperatures, you are wasting money in that case. Yeah, it's because you need more fuel to get the temperatures high. So in general, I can just say, don't do that. It's kind of, it's just a burning of money, and it's also not necessary at all.
Again, thank you so much for that perspective. Hopefully I don't have the name here, the person who asked this question. If there's some other comments, please feel free to place it in the chat. We thank you, Ute, for your perspective on this. We have a question for Yasir regarding emergencies. And so the question is, on average, how long have you seen it take to prepare a coordinated strategy plan for emergencies for WASH and healthcare facility at a country level? And a follow-up question is, how often do you advise updating such a plan when it's created? And then what challenges have you seen implementing the strategy during actual emergencies? So Yasir, if you could talk with us about this.
Thank you, Joanne. As we all know that developing strategies takes time and a bit longer, and buy-in from the different sectors, departments, and within external and internal actors. The current coordinated example comes from the cholera response, which is coming from the GTFCCA, where we have a very clear plan already been put together, and how the strategic movement between the different actors and sectors is coordinated. The WASH roadmap and the WASH actors have a specific initiative that is looking into the effective coordination and collaboration between a public health emergencies, which is very much fixated and focused on the WASH and healthcare facilities. The updates to the strategy would be very context based and how the different activities are changing. So I would suggest that if we are looking into each specific response, there is a response plan already been developed. So if it varies from the different morbidities and mortalities, then it needs to be updated maybe 6 months to 1 year. Some of the challenges faced are syncing the implementation activities and then putting all the different actors in one place to have a bit more coordinated effort. Thank you.
Great, thank you so much, Yasir. And so again, if you have questions, go ahead and place them in the Q&A, not in the chat, because we're only really able to follow on the Q&A. I think the next one that we can go to, so I think we'll use this one as the last one before we do our wrap up. So Claire, we received a question that how can we ensure healthcare workers consistently practice IPC before, during, and after contact with patients in healthcare facilities? And if you can answer this, I'd love to hear it, because having healthcare workers consistently practice IPC can be quite challenging. So if you would give us some of your thoughts on this.
Of course, Joanne, and that's correct. But we do have a model and approach, and Lindsay's smiling because she knows this, because I talk about this model all the time. Consistently is a key word. So the first thing I want to say is it can take a number of years. So one of the WHO manuals where it talks about implementation science, it actually gives a cycle of activity over 5 years. So I think that's the first thing to see here. If we want reliability, we want sustainability, we have to recognise that there's an approach to that and it can take years. But if we're going to think practical and how we might go tomorrow and use a model for improvement, that actually would at least start us on that journey. I'm going to say a few things and then I'll summarise it for everyone. We need to make sure that health workers all have easy access to products, materials and resources. If they don't have easy access, we're making it harder for them to do the right thing every time. We need to make sure that we do monitor at the right times and give feedback. And that feedback will look like different things in different settings. WHO does not recommend a punitive approach, but it will be judged within the culture of where you're trying to make improvement. We need to train people as another element, but we need to train, monitor on what's actually in the policies and the SOPs that people are working to. So if we're training on something different from what they're being told to do at their practical level, we won't help people consistently take the right actions. We also need to help people remember what to do. Training them once, having a policy on a shelf will not help people remember what to do in a busy working day. So make it easy, give them communications and reminders. And importantly, we need a supportive culture around people to be sure we can execute all of this. A culture that brings stability, but flexibility and authority while bringing independence. That will look different in every place. So if we're going to summarise how we can take the journey outside of that sort of 5-year implementation strategy, but if we're going to think about it day to day on improvement approach, we want to build, teach, check, sell, and live the whole experience of working towards infection prevention improvement, but also that relates to elements of WARSH that will come in and play a role in that build, teach, check, sell, and live every day in healthcare.
Oh, that is perfect, Claire. I love those words that you have linked up together. If you don't mind just putting those in the chat so everyone can remember the order of that. That's really great. Thank you so much for adding your thoughts around this. Again, can be very challenging to achieve this, but it sounds like you've laid out a very kind of constructive and thorough plan of how to achieve this with the understanding it's going to take time. So again, thank you so much for that. And please put as much as you can into the chat for the rest of the audience. I am going to go ahead, because we're moving short on time, to ask one final question of all of the panelists, just so that we can hear from each of you, given your respective areas of expertise and experience. For those who are working on WASH in healthcare facilities, what is the one piece of advice that you would give as it relates to your particular area of expertise in terms of things that people can do to improve WASH in healthcare facilities? Just one piece of advice. And I will open it to any who would like to start, but we can start with Ute.
I'm happy to start. So, well,
Okay.
on the waste management part, just start doing things, not just, like wait until you have the perfect solution or something. So you can do so much things without a lot of budget, and you can train people, you can improve segregation, you can do so many things without having really like years of planning and having the right equipment everywhere in place. Just start, and step by step, just improve incrementally your system. And this is something which is, I think, really, really important, without waiting and without, trying to get resources ready and everything perfectly planned. And also just like think out of the box, not only thinking about how can I treat my waste here in my facility, but also to interlink it with the whole health system. So maybe are possibilities to treat the waste in another facility which is nearby. Use reverse logistics, especially for small facilities and so on. So there are so many other possibilities which you can also just focus, or minimize the waste. Look at your procurement, look at recycling of your waste. So there are so many dots and pieces which you can also think of, and not only focusing on treatment equipment and how can I buy my next incinerator. So this is the piece I would like to share here. Thanks.
Thank you so much, Ute. Yasir?
Thank you. The effective use of coordination platform that help different groups involved in emergency response, such as government, humanitarian organization, healthcare providers, and communicate and coordinate effectively. To provide evidence and research papers and case studies, document experiences, lessons learned from past emergencies related to WASH in healthcare facility, consider using collaborative platforms such as our COP to share best practices, exchange knowledge, and engage with other experts in the field. This will help create learning and innovation. Thank you.
Thank you, Yasir. Rahima?
Yes, thank you. With regard to gender equality, disability, and social inclusion, I would advise that the design and management of water, sanitation, and hygiene services in healthcare facilities must consider a variety of user needs. User include women, particularly the one who are giving childbirth, menstruating women, infants, children, older people, people with different abilities, people experiencing any injury or any illness, and female staff as well. The planning, designing, and management of WASH services in healthcare facilities must consider the 3 to 4 elements that are accessibility, safety, privacy, social appropriateness or acceptability, and the comfort of these different users. There is also another element that the women, people with disabilities should be made part of the management committees of healthcare facilities, and their participation should be ensured while designing any kind of solution in that particular healthcare facility, and their participation should be ensured when we are talking about the monitoring approaches as well. Thank you.
Thank you so much, Rahima. Really excellent advice. And now we turn, last but not least, to Claire. What is the one piece of advice that you would give to those working in WASH in healthcare facilities?
So it's not just because Ute and I both work for WHO, but I had exactly the same message. Start somewhere. There's absolutely no doubt. If you know your local situation, then you don't keep looking. And I want to give an example, just that hand hygiene is often been seen as this entrance door to quality and safety. We've seen so many examples around the world where starting with some hand hygiene products has led to set of a enhanced workforce for moving into other areas. So start somewhere, for absolutely sure. That's a great message. And then I just want to say 2 other words, which is communicate and integrate. So communicate with messages that you know will influence. I hope that the new IPC
Oh no, we lost her.
Oh, no, it seems like we've lost Claire. Oh, I know she was saying such wonderful things. Hopefully she'll come back in a few moments or a second or two. Let us give her a second.
Oops, there she is.
See if,
Sorry, I'm here. Sorry.
ah,
I've
there
just-
she is.
I don't know. So yeah, communicate and use that IPC strategy if it helps you. Let's use the recent Lancet publications on the costs associated with WASH in healthcare. We have messages, and I think by integrating and using those messages and the tools that show the intersection between WASH and IPC, I think we can be stronger together. So that's definitely the journey I think we can all go on from now. Thank you. Sorry about that interruption.
Oh, thank you for coming back so quickly. So appreciate all of you. And I really do want to extend a very warm thanks to our entire panel. Thank you so much for taking the time to come and then to prepare for this session. Again, we are so very enriched by your responses and all of the perspectives that you have shared. I'm sure those who were not here will be looking at this video so that they can also learn and hear what it is that you have discussed with us today. Again, thanking Claire Kilpatrick from WHO, Saeed Yassir Ahmad from IMC, International Medical Corps, Ute Piapar, also from WHO, and then Rahima Penwar, Water Aid Pakistan. Thank you so, so much. And I think we have like 2 minutes left. So I'm gonna go ahead and shift over to Haley, who'll close us out with our final comments and announcements. Thank you again, audience, for such great participation and your questions today. Those that we did not get to, we will do our best to answer them within our newsletter and then put it somewhere that everybody can see. Thanks again. Haley.
Great. Thanks so much, Joanne. And yeah, let me just echo Joanne and Lindsay and thank all of the speakers and the audience for all the great questions that we had today. So quickly wrapping up, just a reminder on other ways that you can get involved. We recommend and hope that you would subscribe to our listserv. In joining this listserv, you'll get a monthly newsletter that can keep you updated on events and resources. A lot of the items that were mentioned in the chat, we can share on that newsletter today, but also we'll give you information on previous sessions, upcoming sessions, and any information there. So yeah, feel free to do that. I just put the link for that in the chat. And then additionally, oh yeah, great. This is also the COP website. You can check that out too. I put that link in the chat as well. But also for our newsletter, we're always wanting to learn and hear success stories, also topics for recommendations for future sessions. So feel free to give us suggestions or recommendations for that, to nominate a success story. Maybe something came out of this session today that you want to share and follow up on. We'd love to highlight that in our next newsletter. And then lastly, we have our final event of the COP during the second year that will take place on October 4th. So please stay tuned for more details on that as we wrap up this second year. We really hope to have a good representation and strong topics there and would love to have you join. So thanks so much to everyone. Again, the resources from this session will be available on the COP website, and we look forward to seeing everyone in October.
Have a great rest of your morning, afternoon, or evening. Thank you so much for joining. Bye-bye.
Thank you.
Thank
Thank you
you.
for
Bye.
Thank you so
our
much.
interpreters.
Bye-bye.
Have a good day.
Thank you, interpreters.
Thank
Yeah.
you. Yes. Bye-bye.
Bye.
Take care.
Bye-bye.